Thank you very much. And thank you for inviting me to talk about pharmacology of long-acting antiretrovirals. I've put on this slide my disclosures, which are also published on the URL and in the image below. So I guess the first question is why pharmacology when we know how to give injections and we know how to treat HIV? And the answer is that in the real life deployment of long-acting injectables, and I'm only going to be talking about cabotegravir and rilpivirine in the short time that we have today, and only for treatment and not for PrEP. But in the deployment of these drugs in the real world, we're going to encounter problems that clinical trials don't really inform. So I've listed here some examples. You know, what do you do in someone who's taking metformin, for example, or who develops kidney failure? What do you do with someone who misses clinic appointments and then pitches up 16 weeks pregnant? What do you do with someone who has persistent low-level viremia, for which your laboratory cannot amplify virus for resistance testing? What do you do when patients who are established or about to be established on long-acting injectables develop acute illness and requiring hospitalization or surgery or intensive care and complicated by lots of medical conditions? Okay, and what happens when you start new drugs for all of those medical conditions? So today I'm hoping to help you answer some of these questions using pharmacology as a basis for designing and making treatments safe. So first of all, we need to remind ourselves, what is it that we're trying to prevent? What harm are we trying to prevent? And the answer is that we're trying to prevent treatment failure with emergent resistance, because that's a problem. That's a problem. You start someone on long-acting cabotegravir and rilpivirine, and if they get treatment failure and resistance, then suddenly their options are narrowed considerably to the extent that you might only really be able to feasibly give them a boosted protease inhibitor, which is not exactly where you wanted to be when you started off with treatment. These are data from Atlas 2M, so 152-week analysis, which was recently published in CID. And you can see that there was a comparison of monthly and 2-monthly cabotegravir and rilpivirine, and effectively the two regimens were non-inferior. They met non-inferiority criteria, although numerically the confirmed virological failure rate was higher in the 8-week arm, the 2-month arm, so that's 2.3% versus 0.4%. That's still pretty low, so the risk of failure is pretty low. This is a good regimen. The consequences of failure, however, are very significant, because if you do fail, then more likely than not, you will have resistance, usually to rilpivirine and possibly in a lot of patients to both drugs. And this is a big deal, as we said. And you compare this to something like the ADVANCE study, which is recently published in CID, where patients on dolutegravir regimen, TAF or tenofovir and XTC, for example, 67% of people who are viremic, when you gave them the tablets and monitored adherence, would resuppress. As opposed to a third of patients with efavirenz. This is a high-risk scenario for long-acting injections. Are there any particular risks that we need to worry about? And this is a paper that's very well cited, and I'm sure you're familiar with, looking at risk factors for confirmed virological failure in pooled analysis from Atlas 2M, and FLAIR, so over 1,000 adults. Again, confirmed virological failure was low, but the risk factors were subtype A1, A6, and existence of proviral resistance mutations to rilpivirine, and a BMI of at least 30. Okay, so BMI of at least 30. And this analysis has been expanded to include drug levels. Now you can see that both rilpivirine and cabotegravir trough levels were predictive of failure, and actually BMI fell out of that model. And the reason is this, that patient BMIs have lower drug levels, and so when you include drug levels, then that's the main driver for failure. Now, why does BMI, why is it associated with failure? And it seems likely that one of the biggest risks is that the needle length is too short, and so you're not delivering the drug intramuscularly as you had intended. So here is here's a graph showing in the blue dotted line the plasma levels of cabotegravir in people with a BMI of less than 30. So that's the reference concentrations. And in the orange line are people with BMI of greater than 30 who used a needle length of less than 2 inches. So the standard needle that's used in other patients is 1.5 inches. So if you use a 2-inch, if you use a 1.5-inch needle, you will get much lower levels of cabotegravir, both in the 2-monthly and the monthly regimen. But if you change that to a 2-inch or greater needle, then you do redress some of that deficiency, and you can see that clearly in this presentation at EX from Emily Elliott. What other groups may be more fragile, if you like, or more vulnerable to low drug levels and therefore resistance? Well, patients with polypharmacy and drug interactions, we'll talk about that in a bit. And of course, this happens all the time. You're established on long-acting injections, and then something new happens, an incident morbidity. Okay, you need to start TB treatment or epilepsy treatment or cancer treatment or something like that. Okay, or people who become acutely unwell, people who have poor adherence and miss clinic and injections, or patients who stop suddenly. And then how do you manage blips and persistent low-level viremia? And we'll talk a little bit about that. What I won't cover, because we're not yet sure how this will pan out, is that in real life, prescribers don't always use medicines in the way that they're a license. So some people may, for example, be thinking about splitting the rilpivirine from the cabotegravir dose. Some people may be thinking, even though these are not indicated in the license, about using long-acting injections to bridge certain scenarios, for example, perioperative scenarios where patients are nil by mouth, ITU admissions. Okay, and they are potentially risky because we don't know because there's no clinical trial data informing how to best use these drugs. And so this is not a recommendation to do that, but I think we will need to try and answer some of these questions with future research. And of course, we talked about vulnerable populations, not much data on elderly patients with sarcopenia, frail patients, pregnancy, children, and organ impairment. All right. So we're going to talk about the pharmacology of cabotegravir and rilpivirine. And first of all, the drugs are supplied with syringes and with needles, and the needles are 1.5 inches, as I say. So if your patient has a BMI of greater than 30, you would need to be using your own needles, the 2-inch variety. Cabotegravir is metabolized by UGT1A1 and rilpivirine by cytochrome P 453A4. Now that's important because a lot of drug interactions that affect 3A4 give a much more profound effect than with UGT, for example, and also that rilpivirine. So rilpivirine has also got a different safety profile, I think, in terms of much higher levels of rilpivirine have been associated with QT prolongation, although that's probably not terribly relevant for long-acting injections. You notice that there's low DDI potential both as a perpetrator and as a victim, with some caveats. But for both drugs, detectable concentrations are found 1 year after a single dose, and so that makes managing the tail and stopping treatment quite problematic. Two other additional considerations, which is that when you start injections, the early trials used an oral lead-in period of at least 4 weeks before proceeding to injections. And then when you did start your injections, there's a loading phase, so that's slightly different for 1 month versus 2 months, followed by a maintenance regimen. Right. How do DDIs impacting on long-acting drugs differ from DDIs impacting on the same drugs given orally instead of by injection? And I'm not going to go through the whole lot. You will find the drug interactions that you need to know about on this website, HIV drug interactions, the Liverpool drug interactions website. But I will summarize by batching them up to you. So clearly, you're injecting a drug rather than swallowing it. So gut-based DDIs disappear. So that's any acid-reducing agent for rilpivirine, and that's any divalent cation-containing drugs like antacids, multivitamins, calcium, iron for integrase inhibitors. Now, there are other important differences. So, for example, with moderate inducers of 3A4, they moderately reduce rilpivirine levels, and you can get around that by adding an extra 25 milligrams of rilpivirine. So, betamethasone, not the inhaled one, but the oral betamethasone given for colitis, for example, we would make a recommendation to increase rilpivirine by 25 milligrams. Same with modafinil and rifabutin. Flucloxacillin is a new one for many people. So flucloxacillin turns out to be a moderate inducer, and it can have some pretty profound effects. So, for example, flucloxacillin can give a 38% reduction in tacrolimus levels. It can give an 85% reduction in voriconazole. That's pretty significant. Obviously, there's a difference between 7 days of flucloxacillin and 6 to 12 weeks of flucloxacillin for deep-seated bone infection or for endocarditis, for example. Strong inducers will lower the drugs irrespective of whether they are oral or IM. So that's all the that's rifampicin, rifapentin, St. John's wort, and many of the anti-epileptic drugs. And then lastly, it's not a contraindication in the label, but if you were to be receiving anticoagulants, what is the chance that 2 deep IM injections every 2 months of 3 mils each might be associated with an intramuscular bleed? Well, nobody knows that, actually, and there's surprisingly little data on that, but I think that does require at least some vigilance. It's not a contraindication, but you certainly need to be looking out for it. And as I said, I'm not going to go into this, but the website team have produced a comprehensive review of the drug interactions affecting cabotegravir and rilpivirine, and you can find it on this article below. Right, so other than in drug interactions, are there special populations that we're going to deal with that are not covered in the clinical trials that we've seen in Atlas and FLAIR that we need to know about? So what about renal impairment? So both drugs are liver metabolized. So mild to moderate renal impairment, there should be no dose adjustment. With cabotegravir, it's highly protein bound. It's not expected to have a big effect in terms of pharmacokinetics with end-stage renal failure or with hemodialysis. So can be used with caution, likewise with rilpivirine. Both drugs are excreted through the liver, but UGT is preserved until very, very late on in liver impairment, whereas 3A4 is affected much earlier. So you can see a slight difference here with mild to moderate liver impairment, Child-Pugh A or B. There's no dose adjustment for either drug. For Child-Pugh C decompensated liver disease, use cabotegravir with caution. Bear in mind these patients may have a coagulopathy and may be likely to bleed as well. And then with rilpivirine, 3A4 is affected much earlier. And so you can expect higher rilpivirine levels, and higher rilpivirine levels, as we said earlier on, may be associated with QT prolongation. So this is a red. This is not recommended in severe liver disease. What about pregnancy? limited data to date. There are networks, Impact and Penta, for example, looking at women who become pregnant on long-acting injections. But data from the clinical trials are very limited. So there's 25 pregnancies in the clinical trials, 10 live births, 1 congenital anomaly. Okay. From the cabotegravir side, we know that cabotegravir at very, very high doses, supratherapeutic doses in animals, did show some reproductive toxicity. So there's not a recommendation to use it unless the benefits are greater than the risks. And there might be benefits in terms of convenience, in terms of disclosure, in terms of adherence. With rilpivirine, this is a bigger problem. Again, there's limited data, but we know that the clearance of rilpivirine orally is much greater in the 3rd trimester of pregnancy. So levels drop by about 30% to a level, a drug concentration that was associated with failure, virological failure in phase 3 studies. So the recommendation here is actually to monitor closely, certainly, to consider a switch or perhaps even intensification throughout the period until the postpartum period. Right. Now, what about other populations? So, there is no doubt that the fragile populations, the population left behind by oral-based heart, are the ones that for whom long-acting injections could be game-changing, okay? But we don't know that, frustratingly, because these are populations which are usually excluded from clinical trials. So here's a study from UCSF and San Francisco General, where they looked at 133 people starting on long-acting injections. Not all of them were suppressed, okay? So some of them were already suppressed and some of them were viremic. And then substance use was recorded in about 1/3 of patients, and unstable housing or homelessness in nearly half of patients. So this is a very important group of the population to try and reach. And it was really interesting because the majority of them suppressed very effectively. So by a median of around 33 weeks, 97.5% were projected to be virologically suppressed. Now, of those that weren't virologically suppressed, you would, as you might expect, they were in the viremic patients. 2 showed early virological failure, but in fact, 54 out of 57 remained suppressed. So this is an important area for further research. What do you do when patients don't turn up or turn up late? And so there are clear recommendations in the label, and I direct you there. And they're slightly different for monthly or 2 monthly, but largely relate to the time that's elapsed since the last injection. So if you're late by a month, in other words, 2 months since the last injection, then you can just give a catch-up dose. But if it's longer than that, you have to reload. And the same principles apply for the 2 monthly injection, with a slight complication that 2 monthly injections has 2 loading doses. And if you miss the second loading dose, then you need to manage them as I've listed here. All right. What about lead-in? To lead-in or not? Now we've got numerical differences in confirmed virological failure rates between twice daily and once daily, although both regimens meet non-inferiority criteria. We also have data from oral lead-in versus not oral lead-in. So in the FLAIR study at week 100, a lot of patients transitioned to IM rilpivirine, and around half of them were not given oral lead-in, and half of them got oral lead-in. And interestingly, one of the worries about oral lead-in is that one of the reasons for oral lead-in is that you want to avoid hypersensitivity. There was no hypersensitivity seen and no adverse events leading to withdrawal seen. And the PK was not appreciably different, although the variability was great in both groups, with and without lead-in. Okay, so the FDA has changed its recommendation so that it does no longer require oral lead-in. What do you do about blips? This is an interesting one, and effectively, data from the long-acting injection trials has taught us a lot about blips. Now, we've conventionally and often unfairly, as it turns out, attributed blips to non-adherence, regardless of what the patient may be saying about their good adherence. But in fact, these were patients who were turning up for injections and given injections on time who still blipped. And you can see that the rate of blipping with injections versus oral is no different. So in the blue line is around 522 patients from Atlas 2M and from Flare. And in the purple line is patients given oral-based Triamex, so abacavir, 3-TC, dolutegravir. And the overall 8 to 16% of patients blipped by intention to treat analysis, but this was not associated with confirmed virological failure. All right. And that's also been established with oral-based regimens. Interestingly, persistent low-level viremia is not the same thing. So it may be indicative of a very large reservoir size, but it is, studies have shown that this does predict the risk of failure or resistance, and that these persistent low-level viremias may differ between drugs, and they may have different repercussions. So boosted PI regimens may be more likely to develop blips or low-level viremia, but in fact, resistance is relatively rare. With long-acting injections, the risk of resistance, as we've said, is considerably higher. So what would you do? Well, you would monitor more frequently, and you could tolerate it and just watch. You certainly check for DDIs and check that you're given the right needle length for patients with high BMI. You might, and I think this is a good idea, switch from 8 weeks to 4 weeks, notwithstanding the non-inferiority that was shown earlier on. And you might be able to persuade your virologist to do some fancy, clever thing with the viral tests, which may or may not inform your decision-making. But ultimately, this is I think, a high-risk scenario that you would not want to tolerate for very long. And your choices are either to intensify the regimen, so add other drugs, and you might want to think about a boosted PI or other drugs, or else to switch the regimen. Okay, and again, there's not a lot of data about what to do here, but I think there's enough data to make me worry that tolerating long-term persistent low-level viremia in patients with injectable therapies is a bad idea. All right, and then we're getting near the end now. How do you stop treatment? And the best data for this, in fact, come from cessation of PrEP, where you can see that that levels of drugs are detectable a year down the line, and are much higher for females. So the washout is much longer for females than it is for males. And the SPC is at pains to say that you should very quickly establish the patient on a fully suppressive antiviral regimen no later than the next due dose. And the reason for that is obvious, that you don't want failure with resistance, which a persistent low level of drug would almost inevitably give you. So we're back to the start now. I gave you some scenarios, and you can see now that we say, well, metformin, does cabotegravir have the same drug interactions as dolutegravir for metformin? The answer is no. Cabotegravir does not inhibit those renal transporters that dolutegravir does, although the study has not yet been done. So metformin should be okay with cabotegravir. We talked about kidney failure. We talked about colitis with the betamethasone and missing treatment and pregnancy. And again, I think that there's a lot of concern about how to manage low-level viremia, and we've discussed that today. And of course, the fact that how do you manage new things that happen when you're already on long-acting, or, what would you do with a DOAC? I think it's not contraindicated. You'd watch it. With seizures, you'd either have to pick an anticonvulsant that was less interacting, and you can search the Liverpool website for that. We talked about flucloxacillin, for example, long-term use for treatment of bone infections and endocarditis. So I hope that this has been useful foray into the real-world application of a very exciting new class of drugs and a new route of managing HIV. And I want to end by thanking the Liverpool website group who've done a fantastic job over the years. Thank you very much for listening.